Okay, so we can start the session. And the very first question was, and again I have segregated the questions into two parts. One is like straightforward one-liners, and the second segment is like some conceptual or calculations based questions, right? So we have two parts in this session. So the very first question was about the urban PHC, right? So it was about urban PHC, and it was asked like how much population is catered by these urban PHC, right? So the answer, I think, is pretty clear. It is 50,000. So 1 per 50,000, and that is for urban PHC, right? Now you can, and in fact we have MCQs many times before, and then the question was about the PHC in rural or the tribal settings, right? So in cases of rural this was 30,000, and for tribal it was 20,000, right? So these are the PHC, the populations which are covered by PHC in urban area, rural area and tribal area. Clear? So just remember these values, and I think there is not much to discuss in this particular segment. Although if we can just take few words about the urban PHC. So the population covered is 50,000, right? And then this is for urban PHC. On the top of urban PHC we have urban CHC, and urban CHC, it covers 5 to 6 urban PHC, right? So suppose if I write urban CHC, it will cover 5 to 6 urban PHCs, right? And urban PHCs, it will cater to a population of around 50,000. Clear? So this is the basic concept, urban PHC, right? Chalo. Next question was about TB related web portal in India. So it was about TB related, tuberculosis related web portal in India, and there was many terms which were starting with the words NI. So one is Nikshay, another is Nishchay, and third is Nikusht. Now here the answer is Nikshay, and if actually you broke the terms, if you write it like Nikshay, right? Right, so it's actually a Hindi word, and better or more importantly a Sanskrit word. So Shay is actually for tuberculosis, and if we add Ni before that, then Ni is actually without, right? So this is how you can just remember that Nikshay is for tuberculosis, and then there is this another word Nikusht, right? So again the word Kusht is for leprosy, so this word is actually leprosy. Kusht, right? That is leprosy. And Ni is again without, right? So I think there has to be no confusion between Nikshay and Nikusht. Clear? So these are for the two different conditions. Clear? So again the word Ni is without. Now the word Nishchay is slightly different. It is, Nishchay means determination, right? So that is again a Hindi word, so it means determination, and this is for pregnancy detection, so home based, right? And dots 9 is for the adherence of ATT, right? So for TB related web portal, the answer is Nikshay. Clear? So these are the different terms which I have tried to simplify. So Nikshay is for tuberculosis. Okay, so Nikshay is for web-based solution for monitoring of tuberculosis patient. Nikusht, that is again a web-based solution, but that is for monitoring of leprosy patient, right? And Nishchay, that is home-based pregnancy test kit provided by Government of India. So please remember Nikshay, Nikusht, Nishchay. And since all the words are starting with the words ni, so many times students they just mix up. So make sure you don't mix up, and it's quite easy to understand, right? So Nikshay, Nikusht and Nishchay. And 99 dots is actually related to the therapy or ATT therapy. So there is a code, and that has to be dialed, and that is helpful in monitoring or follow up by the RNTCP staff, right? So this is dots 99. So these are the few terms which were given in the options in this particular question, right? So this is Nikshay. Clear? Then there was this image, and I think this we have already discussed in contraceptives under gynecology, but again I am just repeating the questions. So this is a Lippes loop, right? So this is a Lippes loop, and I've just framed the question in a different manner. So this is again a double S kind of, so this is double S, right? So this is double S configuration, and this was one of the earliest IUCDs, but nowadays it is not into practice. So this is the first generation intrauterine contraceptive, which is, you can say, non-medicated or inert. Clear? So this is Lippes loop, and these are the different generations. The first generations were, of course, the Lippes loop, right? So first generation is Lippes loop. Then the second generation included the copper T, like the second generation included the copper containing IUCDs. Then third generations were the hormonal one. So third generations were progesterone containing, especially progestasert and levonorgestrel, that is Mirena. So remember at least these three generations of IUCDs, right? So here this is progestasert or LNG, that is Mirena, right? Now this is one more question which we have already discussed in obstetrics about the ideal number of antenatal visits, and we discussed in obstetrics that there are two terms. One is minimum and second is ideal, right? So ideal is 12 to 14 because at least once in the first 7 months, right? So if you just break it out, so once in first 7 months, so this will come out to be 7, right? Then twice in 8th month, right? So you can say every 15 days. So here it will come out to be 2, and then weekly in 9th month. So this will come out to be around 4, right? So that is how the total will come out to be 13 for the ideal number of visits, right? Now when we talk about the minimum, then as there are two again fractions, what WHO says or what we follow in India. So WHO says at least 8 visits, but in Indian, as per Government of India, 4 are sufficient, right? So this is the categorization of the number of antenatal visits, whether it is minimum or ideal. Now the question was about ideal, so I think most of you can mark it easily that it has to be 12 to 14. Clear? So please, this is the basic concept. Don't mix up, right? Now, then there was one more question, and it was about a term which refers to the practice of instilling a particular point of view in people's mind and inhibiting their independent thought. So here, what is being done? A particular thought has been, pushed into the people's mind, and they are not using their own thoughts to verify whether it is correct or wrong, whatever, right? So a passive thought insertion kind of thing is done here, and this is known as health propaganda, right? So this is known as health propaganda. So a particular fact is put into the people's mind. So this is health propaganda, right? And this health propaganda is slightly different from health education, right? So health propaganda is what is like the knowledge is instilled in the minds of the people. So it has been pushed, and therefore the persons, the propaganda thing, it prevents thinking, active thinking of the people, right? And we do it by some ready-made slogans. So that is by the way of ready-made slogans. And here there is reflexive behavior and impulsive action. So the persons, they are just following those words without putting their own views. So this is health propaganda. Now if you compare it with health education, now here the person is actively acquiring the knowledge and skill, right? And in cases of propaganda, it is something you can say passive, right? So this is active. So the knowledge and skills are actively acquired in cases of health education, and the people are actually thinking about themselves, or they are giving a thought to the things. So here the people, they are thinking. But in cases of health propaganda, there is no active thinking by the people of the society. They are simply following the slogans or whatever. So in propaganda there is no active thinking, but in health education there is active thinking, right? This is one difference. Then there is reflective behavior as compared to the reflexive behavior of the health propaganda. So there is reflective behavior, and people, they will use their judgment before deciding their actions, right? So they will think about the situation, and then they will apply their knowledge, and then they will come to a final conclusion as to what has to be done. But in cases of health propaganda, there is impulsive action. So the people, they don't give a second thought, they simply follow whatever has been said. So this is health propaganda, and this is how it is different from health education. Clear? So there are two terms which has to be differentiated. One is health education and another is health propaganda. And in health propaganda, there is a passive, you can say, instilling a particular thought into people's mind or a particular slogan into people's mind, and then they don't apply their knowledge or their thoughts, they simply just follow that. So this is health propaganda. So many times, now this is health propaganda, and in simpler terms, many times you must have heard of some slogans which are imposed on the peoples of a community, and that is actually propaganda, right? So if it applies in terms of medical practice, it becomes health propaganda. Clear? So this is propaganda, and that has to be differentiated from health education. Okay. So health education, it is active part, whereas health propaganda is passive. Again, this question we have already discussed in surgery. So most common cancer in females in India, I think this is breast cancer. So no discussion for this, right? So breast cancer. Now this was one core PSM question, and there was like, what percentage of data falls within one standard deviation of the mean in normal distribution, right? So what percentage of data they fall within the purview of one standard deviation, right? So on either side, if you add up, it becomes 68.2, right? So this is on the right, so this is the extent, one standard deviation, right? So this is one standard deviation. And if you talk on either side, say if you talk on this side, if you talk on this side, it is 34.1 on either side, and if you just add it up, it becomes 68.2, right? So in cases of one standard deviation, the answer is 68.2. Clear? So this is 68.2%, right? Then if you talk in terms of two standard deviations, like two standard deviations, the answer is somewhere 95.4, and if you go for three standard deviations, the answer is 99.7, right? So this is, since the question is about one standard deviation, so our answer will be 68.2%. And if the question specifically asks you on one side, then you have to answer 34.1%. if it asks specifically onto one side. Now this is actually the entire extent of one standard deviation, and this is 68.2%, right? So 68.2 is 1, this is 2 standard deviation, and this is 3 standard deviation. Clear? So please remember this much. So 1 standard deviation, this is the 1 standard deviation, then 2 90.4 and 3 99.7. Clear? So this is a basic thing, but yes, it's all like how much you can memorize proper and how much you can recall in the examination. Now then there was a question about a vector which is responsible for transmitting Orencia shushugmashi, right? So Orencia shushugmashi, and the answer is trombiculid mite, right? So this is trombiculid mite, and there are many other rickettsial conditions, and this again is a very important table here, and many times we have question related to either the vector, right? So they will ask you the vector, or sometimes they can ask you the agent. So this is again a very important condition, or the table here about the rickettsial diseases. And if you can just take a few, like there is one condition. Now this condition is actually scrub typhus. Clear? So this is a scrub typhus. So if I write it here, so this is mite, okay, and this is scrub typhus, and it is Orencia shushugamushi, right? So this is shushugamushi. Clear? So this is one more which is actually missing from this table, right? So mite, scrub typhus, Orencia or Rickettsial, shushugamushi. The another important one is the epidemic typhus, okay, which is transmitted by louse and is caused by Rickettsial provazeki. So you can remember the mnemonic lepro here. So you can remember the mnemonic lepro. So again the word L is for louse, right? EP is for epidemic typhus, and pro is for Rickettsial provazeki, right? So you can remember the mnemonic lepro here. Then the next condition which you should remember is the trench fever. This is again transmitted by louse, and it's caused by Rochalimia quintana, right? So again, for this you can remember the mnemonic lottery queen. So L is again for louse, right? The word T is for trench fever, and you can remember the word Rickettsial, the Rochalimia quintana. So queen is for quintana. Clear? So you can just remember the mnemonics, something like this, and this table is again very important. Many times we have question from this particular table. So then endemic typhus, which is also known as murine typhus, this is transmitted by flea and caused by Rickettsia typhi. Then Rocky Mountain spotted fever, and this is caused by Rickettsia rickettsii and transmitted by tick. Then we have Indian tick typhus, which is caused by Rickettsia conuri, transmitted by tick. And lastly, we have the rickettsial pox, which is caused by Rickettsia acari and transmitted by mite, right? So you can just go up with the mnemonics, and you can just make your own mnemonics. So but just try to remember this particular table, right? And of course in question the condition is scrub typhus, which is transmitted by trombiculate mite and caused by Orencia shushugamushi or Rickettsia shushugamushi. Clear? So please remember this. Now then there was a question about crippling fluorosis, and the levels of the fluoride were asked. Now this was slightly difficult question because usually we don't teach in so much detail, but anyway we can just take the opportunity and we can discuss the conditions which arise as per the fluoride concentrations, right? So especially for crippling skeletal fluorosis and severe osteosclerosis, the level of fluoride is more than 10 milligram per deciliter. So if you specifically talk about the answer to this, then to this question it will be more than 10 milligram per deciliter. So this is crippling fluorosis. Now apart from this, many times we have heard of interosseous membrane calcification in fluorosis. So that is known as skeletal fluorosis, and that is seen if the fluoride concentration in the blood is between 3 to 10 milligram per deciliter. So the skeletal fluorosis, and here we see calcification of interosseous membrane. Clear? And this is very clearly seen in forearm, where there is calcification of the interosseous membrane between the radius and the ulna, right? So this is skeletal fluorosis. Then dental fluorosis, if the level of fluoride in the blood is between 1.5 to 3 milligram per deciliter. So you can remember the sequence: dental, skeletal, and finally crippling skeletal fluorosis. So 1.5 to 3, 3 to 10, and more than 10 is the level of fluoride in the blood. Clear? So please remember this much. So this is about crippling skeletal fluorosis. So we can just use the word skeletal over here as well. So this is more than 10 milligram per deciliter of fluoride concentration, right? Now next question, there was a question about the SDG, right? So this is SDG, that is Sustainable Developmental Goals, right? So Sustainable Developmental Goals, and as per this they have laid down certain targets till 2030, and especially for MMR or under 5 mortality rate, right? So this is under 5 mortality rate. Under 5 mortality rate, and here for MMR the target is that they are planning and they want it to pull it below 70, right? So the MMR has to be, as per the SDG goals, by 2030 the MMR has to be less than 70 per 1 lakh by 2030, right? So this is in terms of MMR. Now in terms of under 5 mortality, it has to be as low as 25 per 1000 live birth, right? So this is for under 5 mortality. So the answer will come out to be MMR less than 70 per 1 lakh live births, and under 5 mortality less than 25 per 1000 live births. Now here there is one more thing, and that is neonatal mortality rate, that is NMR, right? And they target to reduce it below 12 per 1000 live births. Clear? So MMR less than 70, under 5 mortality less than 25, and neonatal mortality rate less than 12. Please remember these three, and these are discussed under heading 3, right? So this is 3.1 and this is 3.2. Clear? So again it has two components: neonatal mortality rate and under 5 mortality rate. So neonatal less than 12, under 5 less than 25, and MMR less than 70. Clear? So please remember this, the sustainable development goals and the target till 2030, right? So this is the thing. And then the next question is quite easy question. There is the occupational lung disease which occurs because of exposure to cotton dust, and this is by cyanosis, right? So this is by cyanosis, and I think this is silicosis is because of silica dust, anthracosis this is coal dust, and bagasosis this is sugarcane dust, or what you call molasses, right? So this is bicyanosis because of exposure to cotton dust. Then again, this question we have already discussed in previous sessions. Exclusive breastfeeding has to be continued till a period of 6 months, although a lady can continue breastfeeding till 2 years, right? So she can continue breastfeeding till 2 years, but exclusive has to be for the first 6 months. Later on she can supplement some artificial feeds along with the breastfeed, and the breastfeeding can be continued along with the artificial feeds till a period of 2 years. So maximum time period for breastfeeding is 2 years, but if I say exclusive, it means only breastfeed, nothing else, right? So this means exclusive, only breast milk, nothing else. So this is okay. Now then there was a question about the Anemia Mukt Bharat program, right? So this is Anemia Mukt Bharat program, and it, as the name suggests, it is targeting anemia, and by the way of administration of iron and folic acid supplementation. Now it was asked like what was the true statement about this Anemia Mukt Bharat, and actually what we do here, like if suppose if this is pregnancy, then of course there will be lactation, right? So if you say first 3 months, then 4 to 9 months, and then first 6 months of lactation. So what we do actually, we give iron folic acid during this period and this period, right? So if you look, this is actually 6 months and this is also 6 months, Clear? So we are giving iron folic acid supplementation during the later half of pregnancy, and this is continued in the first 6 months of lactation. So last 6 months of pregnancy continue till first 6 months of lactation. So that is what the approach of iron folic acid supplementation is within the AMB, that is Anemia Mukt Bharat program, right? So what we do here, we give a minimum of 180 days during pregnancy, and that is of course 6 months, right? So this is equivalent to 6 months. Clear? So 180 days in pregnancy, and then 180 days postpartum, that is again 6 months of lactation. Clear? Postpartum is lactation, and this is again pregnancy. So the supplementation has to be continued. Last 6 months of pregnancy, first 6 months of postpartum or lactation phase, you can say, right? So this is the Anemia Mukt Bharat plan, and the content is 60 milligram elemental iron and 500 microgram folic acid. So please remember, this is microgram, right? This is microgram, right? And this is milligram. For iron it is 60 milligram, and for folic acid it is 500 microgram of folic acid, right? So this is Anemia Mukt Bharat. And I think the next question is quite basic. Folic acid deficiency, it will cause neural tube defects, right? So this is neural tube defects, and see, the neural tube defect as such is a very broad term, right? So it can include anencephaly, encephalocele, then meningocele, myelomeningocele. Now these are the commoner terms which we discuss in usually in MCQs. So these all conditions, they come under neural tube defects, right? So you must have heard of spina bifida, right? So this is the broad term under neural tube defects. So it can be anencephaly or myelocele, meningomyelocele or encephalocele. So these all are neural tube defects, and these are prevented by giving folic acid. Clear? So I think this concept must be known to you already. Now coming to the next question, that is about the WHO definition of blindness. Now WHO definition of blindness says, despite best possible correction, right? So we are trying our level best, but despite that the visual acuity remains less than 3/60, right? So this is despite best possible correction, the visual acuity is not more than 3/60, right? So here it is, the visual acuity is less than 3/60, and despite best possible correction. Okay, so this is WHO definition of blindness. Now there was a question about a provision in the Factories Act about the per capita space, right? So what is that minimum amount of space which has to be given to a particular worker in a factory under Factory Act, and that is 500 cubic feet. So it means for every worker there has to be a space of 500 cubic feet at least, so as to avoid overcrowding and hampering with the work. So this is as per the Factories Act, and a minimum of 500 cubic feet of space has to be prescribed to a worker. So this is as per the Factories Act, right? And then there are many other recommendations. I'll be skipping those, but pertaining to the question, this is 500 cubic feet of space. Now another question was about the activated sludge process, and it was asked like, which step is known as the heart of activated sludge process. So heart of activated sludge process, and this is actually the aeration tank, right? So aeration tank is considered to be the heart of activated sludge process. And actually what happens here, there is the involvement of microorganisms, right? And this oxidizes the organic matter, right? So whatever the sewage effluent is coming in aeration tank, it is mixed with microorganisms and then they oxidize the matter, and therefore this is known as the heart of activated sludge process, right? So aeration tank, please remember. Chalo. The next question, this is again a very important question and many times it has been asked in one or other way. So wasting of a child, wasting in a child, and that is assessed by which parameter? Now there are two terms which you need to remember. One is wasting and second is stunting, right? When we talk about wasting, it means there is something related to the weight, and when we are talking about stunting, there is something related to the height, right? So wasting means weight is affected, stunting means height is affected. Now wasting is taken as a indicator of acute malnutrition and stunting is taken as an indicator of chronic malnutrition. Clear? So when we say wasting, this is again an indicator of acute malnutrition, and this is low weight for height, right? And when we say stunting, this is chronic malnutrition and this is height for age. Clear? So this is wasting, which is an indicator of acute malnutrition, right? So weight for height, and this is height for age. Okay, so wasting and stunting, acute malnutrition and chronic malnutrition indicator respectively. Now we will come to some conceptual or calculation based question segment, and in very first question it was observed by a gym owner that if a person who is coming to the gym, if he is drinking iced tea, he is reducing more weight, right? So there are three things: gymnasium, right, iced tea consumption or drinking, and loss of or reduction of weight, rather than there is reduction of weight, right? So these are three things. Now actually what happens if a person is spending time in gym, he will reduce weight, right? So he will reduce weight. But how the gym owner is perceiving? He is saying that the person is drinking iced tea and therefore his weight is reducing. So this is known as indirect association, because the real factor for reduction in weight is actually working out in gym and not drinking iced tea, right? So this kind of association is known as indirect association, and this factor is known as the confounding factor, right? So this is the confounding factor, right? So this is the confounding factor. Clear? So this is direct association. If you do exercise in gym, you will lose weight. That is direct association. But here the person is perceiving in a different manner. He is saying that since the fellow who is coming to the gym is drinking iced tea, so he's losing weight. So this becomes an indirect association, right? So this is indirect association. And for indirect association, you can remember one more example, and just giving you one more example to clarify this. So it was observed that those who are staying at high altitudes, they develop, now here again we can have three factors: iron deficiency, okay, if I write it another way, so iodine deficiency, then high altitudes, and third is endemic goiter, right? So iodine deficiency will lead to endemic goiter or goiter as such, and this is direct association. But people perceive as if those who are living at high altitudes, they are having endemic goiter. This is indirect association. It is just that those who are living at high altitudes have less intake of iodine, and therefore they are getting the endemic goiter, right? So this is a classical example of direct association or indirect association. So there is, as I told you earlier, there is always a confounding factor. This is not the real factor which is causing the disease in discussion, but it is involved indirectly in the discussion of the disease, right? So if we take about the indirect association of altitude and endemic goiter, now endemic goiter is generally found in high altitudes, right? So endemic goiter is found in high altitudes, and therefore people think that those who are staying at high altitudes will have endemic goiter, but it is not the actual reason. So endemic goiter is not due to high altitude, but it is because of environmental deficiency of iodine, right? So this is direct association and indirect association. So any confounding factor, if, or the third factor, if it comes into play, and one who is not involved in the direct causation of the disease, that will be known as the confounding factor, and any association of that confounding factor with the disease will be taken as indirect association. Clear? So this is the concept of direct association and indirect association. Please remember. Now direct is quite easy to understand, because a factor and a disease, they are directly related, like smoking and lung cancer, right? So that is direct association. But if there is any involvement of any third factor in between, then that factor and disease is indirect association, and that factor will be known as the confounding factor, right? So please remember this beautiful concept. Now the next question was about a lady who developed edema and heart failure along with some visual disturbances after consuming some food item, and there was some adulteration in that food item. Now the moment you find the word edema, you have to think of epidemic dropsy, right? So the moment you find the word edema in a case of adulteration, think of epidemic dropsy, nothing else. And we know what is the actual problem in epidemic dropsy. There is contamination of mustard oil with arginine oil. Clear? So there is contamination of mustard oil with arginine oil, and we know that what is the toxin here? That is sanguinarine. Clear? So your answer will come out to be sanguinarine. So the moment you find the word edema in adulteration, think of epidemic dropsy, no other thoughts. So in the image you can clearly see right? So these are all, you can see the pitting edema kind of picture, right? So this is epidemic dropsy, and the characteristic feature is edema. You can say bilateral pitting edema, right? So this is epidemic dropsy, which is caused by adulteration of the mustard oil with arginine oil, which contains sanguinary. Now next question was a calculation based question, and here it was given like there are the total number of births is 4050 and stillbirth was 50, right? So total birth is equal to the sum of live births plus still births, right? So live births and stillbirth, and here this is 4050, this is 50, so this will come out to be 4000, right? So the number of live births are 4000. Now we are finding two things: neonatal deaths, right? So neonatal deaths, then here we have within 7 days and within 8 to 28 days. So if we just write them within 7 days, now this is known as early neonatal period. This is early neonatal. And if I write 8 to 28 days, this is late neonatal. Clear? So the value in early neonatal is 7, and then 8 to 28 is 150. Clear? So this is 50. I'm sorry, this is 50, right? So this is 50 here, so I'll write 50 here. This is 150 here, so I'll write 150. So total neonatal deaths are 200, right? So total neonatal deaths. Clear? So we have got the number of live births, we have got the number of neonatal deaths, total neonatal deaths. So if someone asks you calculate NMR, that is neonatal mortality rate, so obviously you have to include the number of neonates only, that is the one who are born alive and died within 0 to 28 days. So this is the total neonatal, and this is the actual neonatal period. So any death which is occurring within this period will be known as the neonatal death, and therefore you have to exclude stillbirth because they are not counted in neonatal age group, right? So therefore if someone asks you calculate NMR, what you will do? You will take the number of neonatal deaths. So the number of neonatal deaths which are 0 to 28 days, right? So this is 0 to 28 days, and the denominator will be the live births. This is very important here, live births, and it will not be the total births because stillbirths cannot be counted under neonatal deaths. So it has to be live births. So if you can just simply sum up the 200 upon 4000, clear, into 1000, right? So this is very important. In neonates you have to firstly calculate all those deaths which are occurring in the neonatal period, and neonatal period is 0 to first 28 days of life, right? So this period is neonatal period, and therefore that becomes the numerator, and the denominator is total live birth. Please remember, this is total live birth and not the total number of births, which also includes the stillbirth. So please don't because if you take 4050, your answer would be wrong, right? So you have to exclude it. This has to be excluded while calculating neonatal mortality rate. So number of deaths in the neonatal period, that is early neonatal. So again I can, if I just remember, so neonatal period again has two components: early neonatal and late neonatal, right? Early neonatal Now early is 0 to 7 days and late is 8 to 28 days. Clear? And therefore you can calculate the numerator like this, and denominator has to be only the live births, right? So exclude stillbirths. So you will get to have the answer as 50. Clear? So this was a basic calculation for this particular question. So neonatal mortality rate, and again I am repeating, the denominator is per 1000 live births. So students, they usually take the total number of births, and therefore their answer comes out to be wrong. Please mind this. Now again we have a very good questions. Morbidity of a disease is increasing. Now here we take two terms. One is incidence, because these are the indicators. One is incidence and second is prevalence. Fine. So incidence and prevalence, and I think most of you must be knowing that incidence are the number of new cases. Clear? So this is the number of new cases. And what is prevalence? This is new plus old cases in a community, right? So incidence is all the number of new cases which are coming, and prevalence, it includes all the new cases. That is, you can say this is incidence, of course. So incidence plus old cases. Clear? So this is prevalence. Now coming to the question, here morbidity is increasing, and again you must know, you have to remember two terms. One is morbidity and second is mortality, right? So second is mortality. Now if I say mortality means killing or death. Now morbidity is disease, suffering. Patient is not cured, patient is not killed, so that case is persisting as old case. So morbidity means if someone is having a disease and if he is not cured, or if he doesn't die because of that disease, he will add to the pool of the cases and he will come into the old cases, because incidence is all new cases, right? So if the morbidity of a disease is increasing, new cases will keep on coming, right? So new cases will keep on coming. But if morbidity is more, it means the number of old cases will be more, and therefore if you sum up these, the prevalence will be more, right? So therefore your answer will be prevalence will increase, right? So prevalence will increase. It will not have any effect on incidence, which are the number of new cases, but it will affect the number of old cases, which will keep on increasing. And since prevalence is new plus old, and if old will increase, it means prevalence will also increase. So this is how you have to apply the concept in this particular question. More morbidity means the patient is alive with the disease. Mortality means the patient is dead. So if the mortality is more, it means the number of old cases will be less. So that is again a separate concept. I will not confuse too much. For the time being, just remember, if morbidity is more, number of old cases will be more, and therefore the prevalence will be more, right? So everything will be more. Morbidity more, old cases more, prevalence will be more, right? So this is how you have to approach this particular question. The next question we have already discussed in previous sessions. A lady with IUCD is complaining of spotting after 1 month. So this is, you can write spotting here. And for this particular case, we know that whenever IUCD is inserted till 3 months, there might be intermenstrual vaginal bleeding or spotting. So tell the lady, need not worry. This is the usual phenomena after IUCD insertion. So all you can take iron tablets for just to compensate for that blood loss. So reassurance and iron tablets, right? So this can be seen till 3 months. So no need to worry. No need for any evaluation. No need to take out the IUCD. Nothing like that. Now, there is one more calculation based question, and here the father is 68 years, right? And then a person is 68 years, a lady is 59 years, their son is 30 years, and their daughter-in-law is 27 years, and their grandchild is 5 years, right? So if we can just summarize it here, like you can say grandfather 68, grandmother 59, right? Then father 30, then mother 27, and the child 5, right? So these are the ages, right? Okay, so these are the ages. Now the question was about the dependency ratio. So the question was about calculating dependency ratio. Now before calculating dependency ratio, you must know what all age groups are considered as dependent, right? So again, we have two classes, young and elderly. So in young, if the age group is less than 14, if the age is less than 14, and elderly if the age is more than 65. So these together will be taken in the dependency. So this is young and this is elderly, right? So young dependent, elderly dependent, and if you sum them up, it is the numerator in dependency ratio. And then the denominator, this is very important, the denominator has to be the population excluding these age groups. So excluding the young dependents and excluding the elderly dependents. So obviously it comes out to be 15 to 65. So if I just write it simply here, so this is one age group 15 to 65, right? So anything less or anything more, these are all dependents, right? These are all dependents. So more age group, this is elderly, and less age group, this is young. Clear? So this young plus elderly will become the numerator, right? So this will be the numerator here, and the 15 to 65 will become the denominator. So this is the denominator for calculating dependency ratio, right? Now we can apply this concept to the question in discussion, right? So the person less than 15 years of age is this one, right? So we have this one over here, this is less than 15, right? Now this is more than 65, okay, right? And then the remaining ones, this is within the age group of 15 to 65 years. In fact, these all are within the age group of 15 to 65 years, right? So these all are within this age group, okay? So in this age group we have 3 persons, right? So these 3 persons are here, and then in this age group we have 1 person, this is 1 person, right? So this is the numerator part. So what is the numerator? Numerator will come out to be 1 plus 1, and the denominator will be 3. So this is the denominator, and this is the numerator, and again this is the part of numerator. Clear? So this way you can get the dependency ratio, and that would be around 66.6%, right? So this is how we calculate the dependency ratio we have to calculate the dependent first, and that has to be divided by the non-dependent age group into 100. So this is dependency ratio, right? So again, a formula based thing, and very important part is you have to remember the exact formula. That's very important, right? So this is how we calculate the dependency ratio. Then this is one more very good question, and it's like very confusing for the students. Like they think of secondary level of prevention, because this is actually secondary prophylaxis, right? So if a patient is having rheumatic fever, right? So if a patient is having rheumatic fever, we start the patient on secondary prophylaxis, and this is to prevent the rheumatic heart disease or the valvular affections, right? So the term here is secondary prophylaxis, and just thinking of that term, students think that the answer will be secondary level of prevention. Now that is not the case. Please don't get mixed up. Now if you look at the word proper, you will see that we are giving prophylaxis, and prophylaxis is a sort of, you can say, specific protection, and specific protection plus health promotion. This is what? This is primary level of prevention. Got my point? So prophylaxis has to be included in primary level of prevention. Treatment part goes in secondary level, but here we are giving prophylaxis. It is not for treatment, it is for prophylaxis, and therefore the answer has to be primary level of prevention, right? Because this word secondary, because student, we always teach for secondary prophylaxis we will give injection, benzathine, penicillin. So that secondary word actually confuses the student. So this secondary prophylaxis does not mean that it will be secondary level of prevention, because prophylaxis, being a specific protection, comes under primary level of prevention. So I am just repeating again, secondary prophylaxis in rheumatic fever is primary level, and do not correlate secondary prophylaxis with secondary level of prevention. That's not true, right? So this is primary level of prevention. And again, I think most of you must be knowing that what is the time period till we need to give the secondary prophylaxis. So if there is no carditis, if there is no heart involvement, we have to follow two things: either 5 years or 5 years duration, right? So you can just write 5 years of duration. This is duration of injection, benzathine, penicillin, and 21 years of age. So out of these two, whichever is longer, right? Whichever is longer. So suppose the child was of 18 years of age when he had that rheumatic fever, and he was having rheumatic fever without carditis. Now we want to give secondary prophylaxis. So if the patient is 18 years of age, then if you apply, this is rule 1, this is rule 2. So if you apply rule 1 of 5 years, we have to give the injection, benzathine, penicillin in 23 years. If we apply rule 2, in which we are giving till 21 years, we are effectively giving the drug only for 3 years, because he is 18 years, and if you decide to give it for 21 years, we are giving only for 3 years. Now the thing is that this is again 5 years. So we have to look like out of these first and second option, which one is longer. So obviously this one is longer as compared to 21. So we will follow 5-year rule in a child with rheumatic fever at an age of 18 years. Now I'll just give another example to clarify it even more. Suppose that this is scenario A, right? Now I'm giving you scenario B, where the child was of 14 years of age, and again if we apply both the rules, if we give 5 years, that is rule 1, it will be like 19 years of age. Clear? Now if we apply rule 2, where we are giving it till 21 years of age, so again see which one is longer. Obviously 21 years is longer. So in this particular scenario we will not follow this, we will follow this, because in this we are giving the secondary prophylaxis for a longer period of time. So our concept is to give the drug for a longer period of time. So whatever rule, either 5-year rule or till 21 years of age rule, so whatever is time period is longer, we will follow that particular option, right? So this is the secondary prophylaxis for a case with rheumatic fever and without carditis. Now I am not going into other options. So this is just to briefly take the concept of secondary prophylaxis, which is a primary level of prevention. Clear? So this question was, I think it's really good question and very confusing. If the student didn't notice this word, if he simply went for secondary prophylaxis and secondary level, definitely the answer would be wrong. So this is not secondary level, it is primary level, because we are giving prophylaxis, and we know that prophylaxis is a sort of a specific protection which is in primary level of prevention, right? So that's enough for this particular session. I thank all of you for joining me, and as I always say, if you have any query, drop me a message on my WhatsApp number. And for tomorrow 10:30 p.m. we will take anatomy, right? So tomorrow we will take anatomy. So see you till then. Bye bye, good night, take care, and thanks for joining. Good night.